Okay, thank you all for coming. The title of today's lecture, which is the third of a series of four, is called Complex Diagnosis: How to Manage in 20 Minutes, which is difficult. So what are our learning objectives today? We are planning how to make a correct and fast diagnosis. There's no point doing it fast if it's not correct. To some extent, there's no point being correct if it's going to take you more time than you've actually got available. What to do if you can't be certain of the diagnosis? The less time you have, the more difficult it is to be certain. But in any case, there's always times where you can't be certain. What are you going to do? And what's the role of pharmacology? When do we use medications? Okay. So we start with this thing. It's yeah, it's slightly relevant or slightly irrelevant, but I think it's useful. It's interesting, maybe more than that. It's an article that was in Nature last year. Active self-treatment of a facial wound with a biologically active plant by a male Sumatran orangutan. So those who can see the pictures, the one at the top, the orangutan has some sort of wound. He has gone out and he has been seen searching for a particular plant. When he's found that plant, he's chewed it, he's taken the liquid, put it on the wound, and then he's taken the mush and put it on his face. And he's done that repeatedly. So it's very clearly something he's not doing by chance. And this is interesting. The orangutan has been given the name Racus. Jane Goodall first reported self-medication in the form of eating leaves by chimps in the 60s. Other behaviour has been seen by bonobos, gorillas, gibbons, and there's plenty of animals that have been seen to do something that sort of looks a bit like medicine. This, though, is another level. It's gone out of its way to find the medication. This is, in effect, an orangutan doctor or dentist. It's max facts. It's in our part of the world. Moving on. Right. So the title of the lecture, How to Manage in 20 Minutes, was the title of a lecture I gave in 2016. And the question that I really have is, is 20 minutes relevant? How long do people have to deal with urgent care? I want to put on a poll. So the question we have is, how long do you have for an appointment for a new patient emergency on the NHS? If you only work privately, I guess don't answer the question. If you work as a nurse or a dental therapist, I can see there's at least one dental therapist on the call. Hi, Jackie. Oh, a hygienist. Put down what you think is the norm within your clinic for how long is currently booked for these things.
Scott, could you give us the link for the poll?
So what was that question?
Could you give us the link for the
length of an appointment?
No, the link to
Yeah.
answer these questions. There should be a link. How do we get onto it?
Oh no, it should have flashed up on your screen.
Yeah, but how are we supposed to answer it?
Click.
Oh, I see.
don't know exactly.
Okay,
yeah,
thank you.
there's a little circle when you click on it and submit
thank
it.
you. Thank you.
Brilliant. Okay, I'll give time for at least one more person to answer. Okay, we got a fair number of answers there. We can see what I've got here is about 20% of people get half an hour. We've got 7% at 25 minutes, 30% at 20, 35 at 15, and we've still got 10% of people that are going less than that. So in terms of managing in 20 minutes, just over half of the people on this call would get 20 minutes, and about half are getting less than 20 minutes. Okay. The next question is, how long would you want for that appointment? And again, the question should be coming up on the screen. Yeah. So if the patient was a close friend or a relation, how long would you want for that appointment? Obviously, all day is a bit of a silly answer, but I don't fancy seeing any other patients today. But balancing up a certain amount of what's reasonable and how long you need to do that treatment. Okay, brilliant. The vast majority of people have put longer. So we've got 45% at half an hour. Um, we've got 23% going to 60 minutes. Sorry, going to 45 minutes and 8% going to 60 minutes. So clearly, a lot of people are not having quite as long as they would like at the moment. So let's go back to the lecture. Right. So, okay. In the urgent care sector, we have 30 minutes instead of what used to be 20. Why have we been given the extra time? Well, it came in due to COVID, but we've kept it. It's not because of fallow time anymore. I assume nobody is doing that. It's not coffee time. I like coffee, but it isn't coffee time. It isn't because the NHS want to be nice to dentists or nurses or anyone else. That's not the thinking. It's not, and it shouldn't be time to write notes up. It's not, you had 20 minutes to see the patient. Now you've got 20 minutes to see the patient, another 10 to write up copious notes. We do need to write notes, but that's not the extra time. The reason is the NHS commissioners have understood that quality care takes time and are willing to put their necks on the line when the newspapers are full of access problems to provide it. However, the guidance nationally says we should have 20 minutes for an emergency patient. It did previously say 15, so that is an improvement. We should use that time wisely. We should be providing the best possible care we can in that time so that we keep that time, so that we're able to do the dentistry that we all know we should do. Okay, so a sound diagnosis can only be reached when information is systematically, and that's the key word, collected from the patient. I'm quoting Dr. Sharon Stern, specialist endodontist, who I refer to, but who also lectured to my team some years back. Okay, so we need a history. I'm not going to go into it in too much detail because we've done that in the previous lectures. We need an examination and then these tests, every single relevant tooth, percussion, palpation of the sulcus, pocket depth, sensitivity testing. Every single relevant tooth, when you've got an emergency patient in front of you, needs those four tests. And then a radiograph. We see what's going on. At the end of that, we have a possible diagnosis. We may not be totally certain, but hopefully most of the time we're fairly confident. This is a paper from Tara Renton of King's. We've got pain can be either odontogenic, which is pain referring to the teeth or things around the teeth, mucosa, gingiva, maxilla, mandible, periodontal membrane. Dentists do. I assume most people on the call are generalists, maybe the odd specialist, rather than somebody who's dealing just with pain. Non-odontogenic condition is the alternative, and it's conditions that we need to recognise rather than treat. So somebody comes in with a pain that's not sort of tooth or gum related. Yeah, it's not our duty to treat it, but we need to know where to send them, what to do with them, how to treat them, how not to treat them, maybe. There's also things that are a little bit in between temporomandibular joint problems, acute sinusitis, which they come into the emergency dental clinic and we need to know how to deal with them because they are sort of in our remit. So what is non-odontogenic pain? And how does it differ from normal pain or odontogenic pain? This is a paper from the BDJ by Pennington and al. 2024. And it says that we're very used to seeing odontogenic pain, but chronic pain is different. And it's pain that lasts for more than 3 months. And obviously, if somebody, there'll be a first day to it, but generally they're seeing, my pain's been there a long time. You need to think differently. Someone's got, a dental abscess, it will have come up recently. They may have had it on and off prior to that in different ways, but it has periodic times to it. So if, however, one or more of the parties in the conversation, that's the dentist and the patient, think that the default cause of pain is tissue damage, this dissonance does not bode well for successful pain management. So you come in, you've got a problem with your tooth. It's got a hole in it, it's got a crack in it, it's got something physically that you can see. You've got a problem with your gum. There's not enough bone inside it. The gum is swollen, there's a cut, there's something there. Chronic pain does not have some tissue damage attached to it usually. And we need to think differently about how it's working. And we need to communicate that both acute pain, which has got tissue damage, and persistent pain are valid forms of pain that need to be addressed. They need to be addressed differently, but they need to be addressed. It's not, it's all in your mind or something like that. It's real pain, but it's different. So phantom limb pain is a classic one. It's well known. Most people have heard of it. I'll classically talk to patients. I'll say, my late father had a pain in his foot. Well, he didn't have his leg, but it didn't mean that he was making it up. It's a known thing that people have pain from there clearly can't be damage to the foot. It's not there, but it's there. The pain is real. So we'll go to some cases. We've got quite a few cases to show today. Uh, this patient, JN, a male in his late 60s, fit and well. Last visit a year ago. He was seen as an urgent patient February of last year. Intermittent pain upper right 4, not affecting sleep, not affected by hot, cold, or biting, becoming more frequent and intense. He's had it for about a month. He's happy with his dentures, they're chrome, they're 5 years old, and they're a good fit. Soft tissue TMJ nodes, NAD. Soft tissue nodes, NAD. Temporomandibular joint, it's clicking. That's common as anything. No pain. It doesn't lock, but on a couple of occasions it was difficult biting. He saw a specialist, possibly Max Fax, and then another specialist about hearing and dizziness who thought he had broken his jaw in the past. It was little bit odd in that, how the patient wouldn't know he'd broken his jaw, I don't know, but that's the case I've got here. No decay, generalized attrition. When I say no decay, it means no blindingly obvious decay. I haven't checked every tooth and taken bite wings and whatnot. Oral hygiene reasonable. Again, I won't have done a full BPE. Nothing's TTP. Sulcus is normal. The upper right 5 is Endofrost normal as well. Here's our X-ray. That's 3, 4, 5, with the 4 being rotated and having a root canal and a crown on it. He's got a bridge 1, 2, 3, which obviously you only see the 3, which is bubble test negative. So that's when you press on it and see if it's moving because the saliva pulls out of it. Diagnosis to me was uncertain. It could be gingival pain between upper right 3 and 4, and I've not written down on here the pocket depths, but there aren't any significant pockets. Otherwise, I would have put it in as the case report. But having told everyone you've got to write all 4 down, I haven't, and note keeping is never perfect. So I've advised him some chlorhexidine gel if it's sore. I'm going to put a poll up again. How do I do that? I'll stop sharing. And I'm going to put another poll up. So the question here is, would you consider prescribing antibiotics for a patient like JN? Would you do it always or nearly always? Would you do it never or almost never? Sometimes, some patients might, or usually most of the time. Give me a little chance to get the questions up. Okay, great. Would anyone who's put sometime, nobody's put always or usually, which is great. I'm preaching to the converted a little bit, but a fair number of people, just over a third, have put down they would sometimes give antibiotics for this case. Would anyone like to explain their thinking? Anyone want to be brave enough? Unmute yourself if you do. Okay, we'll carry on. So we carry on with this gentleman. 2 months later, I saw him again. The pain comes and goes, and he's pointing now to the upper right four. That's the tooth that's rotated with the root filling, which isn't ideal. I've taken another X-ray of something. I've got part of the four, part of the five on it. I'm not seeing anything there. The pain can affect his sleep or can come on for no reason. It's not affected by hot, it's not affected by cold, it's not affected by biting. Painkillers, standard painkillers are helping. The tests were as before, i.e., there's no deep pockets, there's no problem in the sulcus, nothing's TTP, and anything that should be vital is vital. He's okay biting on cotton wool rolls. So this is where you get one of those cotton wool rolls, get them to bite. Sometimes it hurts when they bite. Tell them to hold it a moment, then get them to open. When they open, sometimes it hurts again. If it hurts on opening, you're looking at a crack usually, and you do it on each tooth and try and get a result that way. It's a bit like a frac finder, but it's not located to an individual cusp. He's had multiple bouts of bilateral sinusitis in the past, but not recently. And the zygomatic tap is normal. So this is where you go like this. If he's getting pain on one side, not the other, that's a positive result, and you're looking at sinusitis. The other one you can do is get them to lean forward. If suddenly it hurts to lean forward up here, again, we're looking at sinusitis. Again, I've not got a diagnosis, but I'm now fairly confident it's not odontogenic. It's not tooth or gum that's causing this. So I discussed the options with the patient, and I feel I've made a mistake here. I've advised him to go to a pain specialist, but I've also spoken of CT scans and endodontists to get because he's got a dodgy root filling and get that checked out. And having offered more than one thing, he's ended up choosing the one I didn't really want him to have done. He's wanted to get a CT done. So I'm just going to stop sharing again for a moment because I've got a question on that, another poll. And that is about CT scans. How often does anyone give their patients a CT scan? This is no longer an NHS question, I guess. It doesn't either they do it themselves or refer for it. I think can put more than one answer down on this one if you wish. Yeah. So if you do it for more than one thing, by all means, put that down. I put my answer in. Again, if you're a nurse or a therapist or a hygienist, put down what is most commonly done where you work. So looking at this, about half the people it's never, um, and about half the people are doing it for implants, about a quarter for endo, 10% for ortho, and about a third for all surgery. So it's becoming more used. Implants, it's sort of recommended for a large number of patients. Endo, some of the specialists are sort of getting to a point where they're thinking of doing it before every case. Now, obviously, they're doing it for very complex cases, and this is slightly outside of urgent dentistry, but someone's put there, we don't have the facility, but we refer to someone who then does it. Yeah, that's slightly different as to they're doing it rather than you're doing it. But but it shows that many of us are now using this technology. Okay. So coming back into the lecture. Right, so he's chosen a CT referral, which I didn't really want him to do, and with hindsight, I shouldn't have offered it to him. 6 months later, he's now getting mild pain in random places. He's not that bothered by it, so he actually decided he wasn't never going to bother going for that CT scan that he chose to have done, and he's also decided not to bother with the referral to a pain specialist. What's causing his pain? I don't know. I want him to go to a pain specialist, but he's not concerned that the pain is bad enough. And we do come across this quite a lot where whatever it was has gone. Is it serious? Well, That's a question. But I didn't hear have any reason to suspect anything serious. Therefore, haven't referred him on. Let's say I'm not suspecting mouth cancer or anything like that. I'm suspecting non-odontogenic pain. Next one's a 94-year-old lady. Hypertension, diabetes, insulin, felodipine, losartan. So common enough stuff. She's had stabbing pain, bottom left for 2 weeks. She's been to A&E, who said go find a dentist. Pain not
I'm
affecting
sorry.
sleep. It comes and goes.
I'm so sorry to
It
interrupt.
Go ahead.
What sort of pain specialist did you mean in the first scenario?
So I refer to a specialist called Leanne Elias, who is oral medicine, I think.
Okay.
There are some of the teaching hospitals have pain specialists. I know that Kings have one certainly, because I've referred there in the past. It's a long form, but it's there. Does that answer the question?
Yes, thank you.
Um, okay. So, patient here, it's not affecting sleep. Pain comes and goes. It's worse when she yawns. She can get pain for no reason, not affected by eating, hot, cold. Painkillers don't seem to help. There's no initial cause. There's no anything, oh, it started when I did X. She doesn't have a lower denture. Tender in the sulcus and on the ridge near lower left 3/4. There's no swelling, there's no redness, no other signs of infection. There's no deep pockets. I haven't done endofrost because the only thing that's there is a root. So I thought about extracting it. It didn't quite sit right. It didn't quite fit. So I decided I chatted to a specialist and colleague, or especially a colleague, and we decided we were going to I recommend you keep a pain diary. So just tell them to write down over the next week when it hurts, what you were doing beforehand, what you did to make it stop, how long it lasted, that sort of thing. And we referred her to the pain specialist. They had a provisional diagnosis of trigeminal neuralgia plus dehydration, and they sent her for various blood tests. Had I have taken out that tooth, I would have traumatized her further, or that root, I would have traumatized her further and made no benefit to her pain. Next case, 84-year-old lady. I don't know the definitive diagnosis there, but the provisional diagnosis is interesting enough. What the point of relevance is, it didn't sit right that it was odontogenic. It was non-odontogenic. Refer on to somebody who can deal with that sort of thing. The next one's another 84-year-old lady this time. And I think we've got a poll on. We'll do a poll on this one. So, general anxiety, arthritis. She's on diazepam, omeprazole, propranolol. Pain affecting sleep, top left, since yesterday. The problem's been there for over a year. She's had an extraction upper left 4, multiple antibiotics. Nose, pocket, sulcus normal. Mild TTP on the 5. Endofrost negative. Here's our X-ray. And I'm going to put poll up. Who is planning to give this lady antibiotics? Sometimes, never, usually, always. Okay, that's great. We've got about 80% never and about 20% sometimes. One person's put usually. I'm preaching to the converted, which is good, but it's important we all hear this, that this isn't an antibiotic case. But those that have thought they would consider it, again, if somebody wants to come on and say why, that'd be interesting to hear as to what the thinking is, what you're seeing in this case that makes you want to consider antibiotics. Okay. So my diagnosis, we've got to have a pulpal diagnosis, and we've got to have an apical diagnosis. What have we got here? So we've got Endophos negative. That could be because she's old and the pulp is miles away from the surface. We've got no obvious caries. We've got no deep pockets, but it is slightly TTP. Are we in the sinus? Don't know. Let's carry on. Let's consider this in more detail. There's an X-ray of the 2 and 3 further forward. Endophos 2 and 3 is also negative, so it's negative everywhere with the cold stuff. But I've then got the electric pulp tester out, which is a useful tool that we should all have. And 1, 2, 3, and 5 are all positive. So these teeth are vital. She's not had a recent respiratory infection. Have you had cold, fever? Have you had cold, COVID, flu, anything up in your sinuses? Zygomatic tap negative. Okay, biting on the cotton will roll. So I'm not thinking along the lines of a fracture too much, because that's the other possibility of a standing tooth. My diagnosis is it's non-odontogenic. I don't see a dental problem there. And I think it's fair to say this lady has suffered severe damage to her teeth in that somebody has pulled out the upper left four, seemingly for no obvious reason. Now, we don't have, we can't prove that because I don't have the pre-op before somebody took that four out. But the fact that taking the four out has made not a blind bit of difference to the pain, it sort of indicates that. She's also had multiple courses of antibiotics. What's that doing to her gut? What's that doing to her general health? Had somebody have thought, well, this isn't dental, we need to send her somewhere else. So dental protection always gives this stat. 80% of patients who have harm don't complain. This lady's had a tooth pulled out for no good reason, potentially. We're not proving it, but potentially. And 80% of complainants haven't had anything harmful done to them, yet still give us grief. There we go, that's life. Next patient's a 37-year-old. Any questions at the moment on that? Okay.
Hi, can you hear me?
Hi, Yasmin.
Hi. I was just wondering, sorry, how did you come to the conclusion for the last lady that it was non-odontogenic pain?
I couldn't see any odontogenic cause. She's had pain for about a year. There's nothing obviously wrong. So she's had pain for more than a year, although it's come on again in the last few days. She's got nothing obviously wrong with any of these teeth by any of the tests I've done. And if you had pain for a year and it was dental, you'd have a hole there, you'd have a fracture, you'd have a deep pocket somewhere. There'd be something going on that would make you think it's dental. I'm not seeing anything. That's the
that's good.
Yeah. Are you Yasmin from the homeless bus?
I am, yes. Sorry.
Welcome. Thanks for coming along. There's a bus that looks after homeless people in all sorts of ways, but dental is one of them, and that's Yasmin. Thank you for doing that. Okay. 37-year-old female.
I have a question regarding this case. So what did you do for her, for this patient?
Referral to oral medicine, pain specialist. I don't have written down on here what the diagnosis was. As again, it's something I think from a dentist perspective, we need to recognize this isn't dental. Not to start taking out teeth, not to start extirpating teeth, not to start giving antibiotics, but to refer them on to the right person who can deal with it. We are, as general dentists, specialists in pulling out teeth and doing root canal treatment and doing gum treatment, but we're not specialists in non-odontogenic pain. It's not our field. Now, if I'd seen this patient first up and she said the pain has just started, yeah, you're more likely to think dental. What would I do if all the tests are negative? Maybe recommend painkillers. Maybe recommend, well, let's have another look at you in a week or two's time and see what's going on. You're not going to refer, if someone said my pain started yesterday, I'm not going to refer to a pain specialist at that immediate stage. But here we've got a history of problems going on for a year and multiple dentists failing to deal with it by trying this and that and not getting anywhere.
Thank you.
The next patient is a 37-year-old. I've not seen this patient, but it's part of running a urgent care system. We get a lot of these sort of cases where I've got that are interesting to see. To share and to discuss. Pain top right, crown upper right 5 done 2 years ago. The dentist has noted no issues seen in the mouth. Percussion, palpation, pocket depth, Endofrost cold test not done or not noted. Not everyone is writing down everything they do, but it does make me wonder, although it does say no issues seen in the mouth, maybe that covers it. Here's our x-ray. We've got an RCT and crown on a 5. We've got not a lot else. Bone levels normal. No obvious caries. No obvious apical pathology. I'm not seeing anything. If anyone else is, if anyone can see obvious caries, please shout it out. Because, sometimes you miss it. Sometimes you're looking at it on a screen with the wrong settings, and somebody else gets it. They advise the dentist, the patient advised the dentist, the dentist advised the patient to use analgesics to manage the pain. So that's fairly good if you don't know what the pain's caused by. We've got another x-ray, it's the same x-ray, we've moved it forward. What should have been done differently though? We should have had these 4 tests: percussion, palpation, pocket depth, Endofrost cold test. Obviously the 5 that you don't need to test, but 4 and 6, are they giving a normal reaction to Endofrost? Why? So that someone else can see it's been done. When the patient comes back with pain a week later, we know what was done the first time. That's what medical records are for. Bite-cotton will roll. So patient come in with pain, I don't know what it is, I need to go through more tests. That one I've just spoken about a few minutes ago. Zygomatic tap, is it sinuses? Get a more detailed pain history. So very often we're quick. We ask them a few questions. We think we know where we're going, and then you have a look, and it's not quite. Something's not right. I don't know what the issue is. Let me ask you some more questions about your pain, and that's things like Socrates or whatever template you're using for that. And listen to the patient. Maybe now you want open questions rather than closed questions, because the closed ones that are trying to be quick and will deal with 90% of patients haven't dealt with this one. I don't know what the answer is for this patient, but I do know that we haven't really resolved it. Maybe the problem's gone away. Who knows? But I think that's where we need to go for extra. This next one is an interesting case that I've seen. One of my patients, 49-year-old, FB, fit and well patient. She's a regular patient. I saw her October 2023, upper right 7, sensitive buccally, and there was mesial caries. Tested normal, nose, percussion, palpation, pocket depth, Endofrost. She had a very tender spot probing upper right 7 mid-buccal and sensitive to air spray with the buccal margin when it wasn't covered by my finger. So I'm thinking, there's some sensitivity. We did a routine composite filling and put some fluoride varnish buccally. That's a photograph of the cavity. I don't know how clearly anyone can see it, but it's not a particularly large cavity or a particularly deep cavity. And there's my filling, which is, I'm sure those that into staining and glazing and shaping will say it's not perfect, but I think functionally it's pretty good. I'm happy with it. It's an upper 7s. I'll happily debate whether it needs cosmetics on it, but there we go. What happened? A week later, so I've done a filling, totally routine, not thought anything about it. A week later, she's in. She's got pain in that tooth whenever it's touched with anything, even with room temperature water. The pain is lingering for 20 minutes. It's not getting any better. The painkillers aren't. She hasn't taken painkillers all week, but it's not. The pain is not there. It's constantly there. It's all day. So it's every day. It's not affecting her sleep. The filling is intact. I've checked that. It hasn't come out. It hasn't broken. The occlusion is normal. You check the bite. You do it at the time of the filling, but you check it again a week later. There's my x-ray. The filling is deepish, but not hideously so. We've got an RCT and crown on the 6. What's going on? Anyone want to shout out an answer? I wasn't sure. Fairly confident it's odontogenic in the sense that I'd just done a filling and it started at the point of the filling. Someone's got irreversible pulpitis, possibly. Low grade it would be. Yeah, I would say if this was irreversible pulpitis, I'd be looking at possibly biodenting it. Crack cuts, yes, possibly. Sensitivity to the bond. Okay. Radhika, do you want to elaborate on that one a bit? Okay. Yeah, something's happening within the filling, possibly. So
Can
going
I,
on more with, oh, go on.
sorry to interrupt. Can I just contribute something? With the composite fillings, sensitivity post-operatively is common. So I think my colleague was just trying to say it's sensitivity to bond. Maybe it's relating to the bond not being placed, or maybe over drying, or maybe it's during the procedure something happened that has led to the sensitivity afterwards, possibly.
Yeah, that all sounds pretty good. Yeah, something in my technique, and it's me that did it. So something in my technique hasn't been done correctly or done perfectly or whatever it might be. And someone's dehydrated genital glands. Thank you, Radhika. Something about that has caused her pain. So a CBCT was taken with no significant issues. I'm going to have to try and work out what the exact timings of this were. Probably come up. The RCT had been done by a specialist 5 years previously, and I think there was a specialist that recommended this CT scan to be done. The 2 months later, the patient. That was it. 2 months later, the patient was thinking the pain is coming from the 6, not the 7. Again, everything's normal, but now we've got the gums are very tender on probing on the 6, mid-buccal, mid-palatal. That's why we took the CT, sorry. I suspect at the time when I did it, I would have gone for, put some fluoride varnish on and try to desensitize as a non-invasive thing, or almost non-invasive treatment. The endofrost is now extremely sensitive on the 7, but also extremely sensitive on the 5. Now, the 5 has got nothing wrong with it at all. And that's why it's important to test adjacent teeth. Because if you just test the one tooth that you think is relevant, you end up potentially saying, that's really hurting, that must need treatment. Well, if all the teeth are really sensitive to cold, maybe they don't. Cavity floor fracture, possible. Not visible on the high magnification, but possible as another possible diagnosis. So we carry on with her. Both myself and both the specialist and the patient decided that the endodontist wouldn't spot something I hadn't. So that's why they went for the CT scan. 5 months later, mostly okay, can get a slight pulse twinge with hard foods and sometimes with liquids. The pocketing on the 6 is 4 millimeters. It's a bit tender with bleeding on probing. There's no crack visible at higher magnification. Nothing's TTP. And now we've got endofrost totally normal on the 7. I'm still not 100% sure what it is. And all these things that you've mentioned are sort of there. Is it low-grade pulpitis? Is it a fracture on the 6, maybe? Is it sinusitis? Is it something non-odontological? But my management broadly was monitor. That was decided between myself, the patient, and the specialist endodontist. A year later, the patient had pretty much forgotten about the problem, and then on questioning said occasional faint twinges, and the tests were all normal. Could we have got her less pain during that time? Probably. Certainly if we'd done the filling better, potentially. But I think we were right not to intervene, not to go in and start doing a root canal, not to go in and start thinking about taking out the 6. And again, it's showing that I don't know all the answers, and none of us do, but it's making sure we share it with colleagues that we think are best placed to help us, specialist endodontists, pain specialists, etc. A male, 22-year-old, fit and well. So we've had a few of the elderly patients. We're going down the age groups here. It's seen by a colleague of mine. Continuous pain, upper right quadrant.
Sorry,
Go
if
ahead.
I can interrupt, Alicia. So, what was the final thing for her? Was there any answer for her?
Was
Sorry
there
if I
any?
missed anything. Any answer for her, like for her things, or are we just gonna wait and see?
We don't have a definitive diagnosis, but a year on, what we have is the problem's gone away and the the testing is normal. So we've not, it's not somebody's just got no pain, but when you test it, the tooth's non-vital. Well, it was irreversible pulpitis, now necrosis. It's not that. Everything's still vital. The pockets are not too deep. And the problem seems to have gone away. I'm going for something, if you ask me to guess, it's some sort of problem relating to the filling, possibly over drying, possibly technique not quite right on the day that has created a problem, but that we didn't need to over intervene afterwards. Taking the filling out and trying again might have helped, but might have just made a deeper hole nearer the pulp and set on the lines towards a root canal. Have I considered replacing the composite with Biodentine? Yeah, I would have done. I would have considered that as an option. In this case, it seems as if we didn't need to. And again, there's lots of ways of doing it. Rushing to drill in deeper in the absence of a diagnosis is always a question, and that's something I'll come to. So this guy, 22-year-old,
I've got a question.
pain upper right quadrant, all teeth mild TTP, sulcus pockets endofrost normal. And here's our X-ray. Anyone want to point out the disease you can see on the X-ray? Well, 6, 7, 8, there isn't really anything. 5, there's no caries. Can't see the apex. So, is someone taking a bite wing? Worth a try. Let's see if we can see any caries there. I mean, you've got overlap, so I guess you could argue your X-ray is not 100% perfect, but seeing you haven't got overlap between 7 and 8 and between 5 and 6, I think it's probably as good as you're going to get it. Trying to take a flat thing of a curved object is always going to create an issue. But there's nothing obvious, no obvious caries or fractures. Tender right TMJ, right lateral pterygoid, severe attrition for age, generalized. So diagnosis, provisionally bruxism-induced pain, maybe. A second opinion was sought because the dentist didn't quite sit right, it didn't quite fit. So we'll redo the checks. Always worth redoing them. If you're on your own, redo them again. Caries on the 6th on this patient. Distally, maybe.
Wendy.
Couple of you seeing it. I'm not seeing it myself, but maybe. Certainly there's overlap, so it could be right. We'll come to it. We've now got 2 dentists looking in. I'll answer Humera's question afterwards. So all checks redone with identical results. Biting, relieving from biting with cotton wool roll is okay. So recheck the history. Give me the pain a bit more. Recent upper respiratory tract infection. Zygomatic TAC positive on the right side only. I'm going for acute sinusitis here. I always tell patients this is the best diagnosis you can get from a dentist. Why? You don't need antibiotics. Analgesics, take paracetamol, ibuprofen. Things like nasal saline, nasal decongestants, you can consider them, but there's not a lot of evidence for it. I used to quite like, if you've got a cold, you stick your head over a bucket of steam with some Obas oil in it. But there's no real evidence for any of this stuff working. Just it feels nice, and that's a nice guidance. You certainly don't need any dentistry, which is why people like it. No teeth out, no caries. And the reason there's no caries in this case is it's borderline on the X-ray, fair enough, but 2 different dentists have had a look in the mouth. One of them, I think, had loops on. I'm fairly confident that's not causing the pain. May have had early caries, might need some fluoride or some filling or whatever, but it wasn't causing the pain. Question was about diagnosis working at 111 emergency service. What should you do? If you're working within the 111 service that I run, there's always more than one dentist there. Speak to the guy next door. And there's also always, unless you're working past midnight, somebody on call you can ask as well, which is me or one of my senior colleagues. If you're on, the question really is, what do you do if you're on your own? Redo the test yourself, and then this slide will come to it. What do you do if you can't be certain of the diagnosis? And whoever you are, you can't always be certain. If in doubt, first do no harm. Primum non nocere. I don't know if my Latin pronunciation is any good, but the Latin is attributed to a Greek, for Hippocrates from the 5th century BCE. If anyone can explain quite why that is, I'll be interested, just as a student of history. You start the treatment with what you're sure of. You redo the test, the 4 that I always talk of, and then the additional ones. You recheck the history. Don't be pressured to make the wrong decision. If the patient says, oh, I must have something. No, I don't know what the problem is. I can categorically state it's not X, but I don't know what's wrong with you. Consider, though, fractures, jaw joint, sinuses, cardiac, severe pain, left side worse when you go up the stairs, 999. It's very rare, but it does happen. Non-odontological causes, that's a key one. Is it dental? We don't diagnose outside our area of expertise. Anecdotally, I find patients really latch on to these wrong diagnoses and wrong management strategies. I was told 20 years ago that I've got trigeminal neuralgia, and whenever the pain comes, I should get antibiotics. My servant of a dentist 20 years ago told me that it must be right. And we now have to get this patient out of that, because as much as anything, that diagnosis, which may or may not be right, but certainly hasn't been reached by any systematic method or necessary training and skill, but has come with a wrong management plan that we have to unpick because it's creating harm. What is the role of pharmacology in these cases? Ibuprofen 600, maybe 800. I think the guidance is 600 though, 3 times a day. Paracetamol, 1,000 milligrams 4 times a day. You can take both, assuming you've not got a problem with ibuprofen. Look at the Oxford League table of analgesic efficacy. Paracetamol, ibuprofen is pretty high up there. Antibiotics are not indicated on any of the cases we've said today. There is no sign of infection, let alone spreading infection. Borderline if inflammation is relevant in any of these patients. So, has anyone read this book, Talent is Overrated? What Really Separates World-Class Performers from Everybody Else by Jeff Colvin? Anyone want to shout out they've read it? Okay. If you have read it, maybe I lent it to you, and can I have it back, please? But what it talks about is deliberate practice. Nobody has innate talent. Nobody is brilliant at dentistry. Nobody is born brilliant at taking teeth out, at endos or ortho or anything else. No specialist that does the most perfect stuff on Instagram is born that way. To get good at something, it says you need 10,000 hours of deliberate practice. The 10,000 hours is a round number. You don't suddenly become good at 10,000, just as you don't suddenly become fit when you do 10,000 steps. But it's aiming a lot of time needs to be spent to get good at something. And it's deliberate practice. You can be the most experienced dentist. You've been going for 30 years, 40 years, 50 years, and you're still not very good at it. And we all know somebody who fits that category, and we wouldn't want to put our mouth anywhere near this guy or girl, because we don't think they're that good at it. But what they are is good at something. They've been practicing something over these years, and it's not they're not good at anything. But if, for example, you've got a dentist who every time he sees a toothache gives an antibiotic over 50 years, it's still doing it. He's still not the right guy to be seeing emergency dental patients in 2025. I don't think he was the right guy in 1975 either, for what it's worth, but it was more acceptable back then. I started in 99, and I was lucky enough to be in a VT practice that gave me experience of 1960s dentistry. So I feel that I've now got many decades more experience than I ever actually have. We can't all aim to be we can all aim to be world-class emergency dentists. We're not in a competition to be as I saw on on Facebook this week, best veneers in all of London. You have to ask the question, who's second? How did you make a competition to find out you were number one? And in which, who were the others in the top three? But we all know a dentist who is below the level of Rakus the orangutan. Again, my VT practice. No, that's not true. That's libelous, isn't it? We want to be as good as we can, and we want to keep learning, keep trying to improve. Okay, thank you very much. The next lecture I'm giving is next week. Why do different dentists treat patients differently? And within that, it's got a lot about things like medical history and when it affects what we're doing in urgent practice. And a lot of us get worried. Oh, the patient's got a medical history. I better not do anything. When is that correct? When is that not correct? I hope to see as many as you can there next week. If anyone's got questions, please contact me, Scott Aaron at hudc.co.uk. And we'll have a look if there's any questions now in the chat. Thank you all very much. I'm going to stop the recording. So questions can be
Hi, Scott.
what's the word? Given